In today's studio session, we explore efforts to stem the spread of Omicron as it fuels an explosive surge in daily infections. For more, I have Dr. Kim Sing-taek from Institute Pasteur Korea. Dr. Kim, it's good to see you again.
Good afternoon.
I also have Professor David Kwok from Suncheon University. Welcome back, Professor Kwok.
Thanks for having me.
Dr. Kim, the Lunar New Year holiday came to an end this past Wednesday. When do you expect to see the impact of the rampant, widespread holiday travel on our daily COVID-19 tally?
Well, there's some typical disease course of this COVID-19, and once the person is exposed to the virus, this is SARS-CoV-2, and then the virus needs some time to just before some developing the symptoms. This time we call just the incubation period. So the most of the virus that we experienced previously, before just Omicron, that was actually on the average like 4 to 5 days. But it can actually just varies between like maybe 2 days to the 14 days. But the Omicron case, recently according to the report is that maybe the incubation period maybe just shorter, 2 to 3 days compared to the prior variant. So then we are actually just start to just seeing the effect of the holidays effect, and then probably we'll see this effect until the next week as well.
Right. Mm-hmm. And Professor Kwok, as my colleague Min Jung mentioned earlier, social restrictions have been, they've decided to maintain our social restrictions, which means up to 6 people can gather socially, and dining and drinking establishments can stay open until 9 in the evening. Do you believe these measures are adequate in light of our current challenge posed by Omicron?
Well, it's hard for me to comment on the adequacy of these distancing restrictions. Primarily because we're already seeing the spiking numbers, and it's reached above 20,000 already, and quite suspected of going even much higher. Not entirely sure if keeping the way it is in order to curb the transmission is the right way to go in this case. Because as we all know by now, Omicron is set to cause slightly less of the severity. And also we now know who is spreading and who should be protected. And also we know how it spreads, so the physicality matters in the transmission of virus. So rather than just keeping the same maintenance mechanisms, such as keeping in within the certain hours and certain numbers, we should, I think, focus more on the physical side of it, meaning ventilation. Also, the targeted age. So the group of people who are more vulnerable to having the disease severely should be more restricted of such social gatherings, but rather for those people who are less likely to do so, could be given a little slack and be walked around, primarily because this is also a chance for the nation to gain natural immunity. The KDCA, when it announced that we are going to keep the distancing guidelines about this time, they already mentioned that the primary reason we need to still keep the restriction is because we haven't gotten much natural immunity over the past courses, as opposed to many other Western countries or other countries have done so. If we keep curbing the way we do and keep only the strictest social distancing, there's not going to be another chance for us to gain that much of an natural immunity, so per se. Obviously, vaccination is probably the one most important prevention method we still need to keep. But also, in addition, I think there needs to be changes made to the fine social distancing guidelines so that we protect the most vulnerable, but yet also attempt to gain the natural immunity while we can, while we know that this Omicron spread could possibly cause less severe cases. So this is just primarily my personal view, and I know it may sound a little bit dangerous to some people, but I also think at the same time this could be the chance that we could gain for the whole nation to obtain a quite high of a natural immunity rate.
Right. Dr. Kim, reinfection cases are also causing quite a bit of alarm amid the spread of Omicron. And having said that, how does this reality compare to that witnessed during the spread of the Delta variant?
Well, there was the report from the UK, comparing the reinfection rate, and the reinfection rate with the Omicron variant is approximately 10%. But compared to Omicron, some reinfection rate with some previous variant, including Alpha or just Delta, is just about 1.4%. And then one of the major difference in this case is the just immune status of the people after just sort of just natural infection or even just the vaccination. So the one of the key different attributes of the Omicron is that it's a very high contagiousness. And according to the study published from the Danish researchers is that they compared the two different variants, the Delta and then Omicron at the same time. And then basically just the viral load was very similar between the two viruses. But then the major difference is that that actually explains the very highly spreading the characteristics of Omicron is that it's immune evasiveness. The immune evasive means is that our immune status, whether it is acquired by the natural infection or just a vaccination, this is all just by the some very early viruses, very early original type of viruses. And this immunity actually does not protect just adequately because the some number of dozens of mutation that is actually being shown by the Omicron variant somehow just evades the neutralization by this natural immunity or just vaccine-induced immunity. So that actually explains why we are seeing so many reinfection cases due to the some Delta Omicron variant right now.
Right, and as Dr. Kim has mentioned now, amid concerns over reinfections and breakthrough infections, a recent study shows COVID-19 infection before or after COVID-19 vaccination can generate super immunity. For more, I have Professor Marcel Kerlin at the Oregon Health and Science University. Professor Kerlin, it's a pleasure to speak to you again.
Sunny, it's good to be with you.
Right. Now, Professor, the last time we spoke, you shared findings that showed breakthrough infections paved the path to superimmunity. And now you've found that COVID-19 vaccination after infection can create the same level of protection. How does that level, Professor, compare to the level seen in vaccinated people who perhaps had not previously been infected with COVID-19?
Yeah, that's a really good point. So this combination of infection followed by vaccination seems to result in similar, very high levels of immunity. They're different in three important ways. Number one, the amount of antibody present is much higher. But secondly, the quality of the antibody is much better. So that means an antibody can bind to a virus but do nothing. And in contrast, these antibodies, they're much better at neutralizing the virus so it can't escape. So that's very important. And then the final thing is these antibodies are better at coping with viruses that maybe you haven't even seen before. So in many of these breakthrough cases, and let's say they had Delta, it turns out that those antibodies are much better at neutralizing even Omicron, for example. We've tested Omicron. So in three ways, they're much better.
Right. Professor Kerlin, going back to your study then, would it be correct to assume that the sequence of the events are irrelevant with regard to the level of immunity created? I'm talking about the events such as the actions of vaccination and infection, of course.
That's right. So it's a very good question. The order in which these exposures come does not matter. So if you're infected first and then vaccinated, or vaccinated first and then infected, it doesn't seem to make much difference. It's the combination itself that raises the immunity to this level. The other very important thing is that if you're vaccinated alone, the level of your immune responses depend on your age. So if you're much older, when you get vaccinated, you just don't mount as good an immune response. But in contrast, these combined immune responses, it doesn't really matter how old you are. It seems as though whether you're 20 or 65, you're still going to develop very strong immune responses. And I think the significance of all of this, I was listening to Dr. Kim and Dr. Kwok, and they were talking about the epidemiologic factors. I think what's very important here is that as time goes on, of course, more and more people get vaccinated and more people get exposed. And so a greater fraction of the population, both in Korea and in the world as a whole, will fall into this category. And therefore, we hope and think will be better protected against not only Omicron or the variant of the day, but future variants as well.
Right, hopefully that will be the case. Professor Kwok, how do these findings compare to perhaps those of other diseases? Basically, is it common for relevant vaccination after infection to result in greater immunity?
Well, I haven't personally come across a particular study that compared the level of immunity that natural immunity caused after vaccination versus the vaccination alone. But if we think about influenza, for example, it doesn't necessarily cause for a person who's had breakthrough infection after vaccinations to be protected from having influenza again the next year. So in that regards, I don't think for other diseases, this particular study really implements the same way. But I hope that Professor Curlin can also help me out on this. But the reason why we see superimmunity from the people having breakthrough infections is probably because after the boost of the immunity through formation of certain monoclonal or multiclonal antibodies against a certain part of the virus, after having a natural infection, the person would also be exposed to the whole parts of the virus with what's called multiples of epitopes. Epitopes are the areas where we are, once exposed, create these morphological antibodies against, and in the future, those antibodies will protect us from intrusions of viruses containing a similar epitope. Meaning, vaccination creates only a narrow vision of morphological antibodies as opposed to natural infections, because the whole virus is exposed in the human body. A whole diverse parts of antibodies are created to form against the whole virus. So I think it that way, scientifically speaking, it's quite natural that that we'll be able to see from breakthrough cases, those people will be much better immunized, even for future possible variants as well.
Right. Professor Curlin, given your findings, how do you respond to questions by people wondering whether it would be wise then to expose, like Professor Kwok had mentioned earlier, to expose a healthy portion of the public perhaps to COVID-19 who have been vaccinated to ensure superimmunity? I mean, we are trying to live with COVID-19 hopefully in the near future.
That's right. Well, in past epidemics where we didn't have modern tools, this is essentially what happened. Every respiratory epidemic, and we've had many, they all eventually end. And I think a big part of that is that the virus encounters an increasingly immune population through the action of infection, of course. But what's different about COVID is that it's taken such a large toll in terms of our elderly and more at-risk folks. And so with today's tools, we do have vaccination. I would say mostly the recommendation is not to get COVID in order to avoid getting COVID. If you have your choice, get vaccinated and then get boosted. We know that that also creates very high levels of immunity. And hopefully, if you are unfortunate enough to get infected after that, then the silver lining is that your immune responses are going to be very good. Hopefully, you had very mild disease because you were fully vaccinated. And your immune responses will likely be very good and likely protect against future variants, as Dr. Kwok says. And I incidentally also agree with him that the natural infection, which presents the body with all of the different facets of the virus, gives you a broader look at it, and therefore your immune responses are also broader.
Right. Professor Curlin, there is widespread belief that Omicron has reached its peak over in the US. Do you share this outlook?
I do. The Omicron virus, we've been tracking the epidemiologic curves, and it came on with great speed, much steeper onset than previous variants when you look at the timeline. But it's also clearly now dropping in the number of new cases. There are some lagging indicators, such as hospitalizations and deaths, that will certainly still be high. But the number of new cases is the first indication that the wave is on the wane, and we are seeing that.
Right, and hopefully Korea will see it soon too. All right, Professor Curlin, thank you very much for making the time to join us live yet again with your insights.
It's always a pleasure, Sunny.
Right, then back here in the studio, Dr. Kim. As my colleagues mentioned earlier, a number of European countries are choosing to adopt a new normal amid the presence of Omicron, despite warnings by the WHO. How do you respond?
I think those countries seem to just confident of their controlling the number of just severe cases, and also the entire just population is actually just way smaller than the other countries, even just Korea. So they seem to be very confident on the controlling that things. But the concerns of the WHO is also just worthwhile, because the some countries like the US, they are actually seeing just more death case compared to the previous peaks. So then I think in the end, this is living with the COVID-19 is ultimately the way everyone has to go. But then there's some timely just decision, because once we just go through and experience the peak infection, then we can think about just living with the COVID-19. And then one of the key issues is in terms of just the authorities that just managing the level of just total infection, and also just now even just importantly just the number of just severe cases, which is the number that our just the healthcare system can actually deal with, not to be overwhelmed by these numbers.
Right. Professor Kwok, given the data shared by authorities here on the use of rapid antigen tests, what can you share with us about their accuracy?
Right. So recently we've seen a couple of reports saying that for those people who are tested positive through the antigen test, ended up testing negative in the PCR, and the sensitivity rate out of it came out to be about 76% or so. This is not something entirely new. However, when we began talking about the self-test kit, which was the exact same type of an antigen test that was being used, at the time of its consumption, really even the sensitivity and specificity were quite lower when compared to the PCR testing. That's kind of obvious, because PCR testing is like the last resort, ultimate type of a test, which can detect even a particle of a whole virus. So the testing positive in the PCR does not clinically necessarily mean that we have a live virus inside our body, but instead it shows our exposure to the virus, and depending on the level of it, we clinically make decision whether or not the person could have been infected. Now, going back to the antigens test, however, even from the beginning, we suspected that the specificity of the antigen test to be quite low, as much as 40% compared to the PCR test. What that means is that it can possibly detect a person negative who's actually positive almost in half of all the tests that should test it positive. Now, going back clinically, in this Omicron spread, how much would that matter? I do think that there needs to be a certain level of accuracy that we should expect from also these antigen tests, because we're going to use to count the daily counts and whatnot. But also, Omicron is going to spike up no matter what. Even if we count, let's say, 30,000, 40,000 per day, depending on the situation, it's still going to go up until its peak, and it's going to start dropping from then on. Antigen test, as opposed to PCR test, has no difference, clinically speaking, caring for a certain level of patients. Elderly patients who are more vulnerable patients are still being tested through PCR tests. People who have been positive, who came up positive through antigen tests, also are tested with PCR tests to confirm their diagnosis. So at this point, I think the accuracy, even though I'm not completely satisfied with the numbers exactly, would suffice in its clinical use, because it still brings up the numbers that we need to care for, but it still won't affect the number or the speed of the number, how fast it will go up to the peak.
Right. Dr. Kim, some 80% of COVID-19 patients who were offered Paxlovid reportedly experienced an ease in symptoms. How or what does this percentage mean in terms of treatment efficacy?
Well, this 80% of efficacy is very similar to the efficacy that we actually observed in the phase 3 clinical trials. That's the actually 88 or 89%. And then this 80% number is the number that we actually obtained from real life experience. And I think this is good. And then to appreciate this number, and then to whether this is a really good number or not, I think it would be better to just compare with the Tamiflu. So Tamiflu for the influenza infection, they're very successful just a drug. But according to the drug, just the makers, the actual efficacy of Tamiflu is that actually just reducing the complication such as pneumonia by the 44%, and also just reducing hospitalization 63%. So compared to these numbers, the more than 80% is pretty good. And then maybe at this time we can also think about the other some therapeutic options for the COVID-19, and not for the severe COVID-19, but for the patient with the some mild COVID-19 to just prevent the progression to severe disease. There are actually now just we have several options. At least the number one actually priority would be just still just a Paxlovid, and then now we actually I told you the 88 or 89% of clinical efficacy. And the second option is not in Korea, not available in Korea, but in the US, the sotrovimab. This is a monoclonal antibody. There are several just monoclonal antibodies that were successfully developed, but the most of them, including the Eli Lilly and the Regeneron, and even just a Korean one, the Celltrion, it did not show a very good just neutralizing capacity, especially against the Omicron. But sotrovimab, this was developed by the GSK and the Via Biotech, still just holds very good, still just a very good neutralizing capacity. So this is kind of a second line of just option for the treating just a mild COVID-19. And then third option is the remdesivir. The remdesivir was originally just used for the severe COVID-19 patient, but just previously I just talked about just the remdesivir use for the even just the mild COVID-19 patient. And then there was some clinical trial for a mild COVID-19 patient, and then the clinical efficacy was just 87%. Actually, just reduced hospitalization and all case deaths. So this is real good. And although this is an injection drug and a 3-day course, I think the efficacy is pretty good. And then probably the last option is a molnupiravir, and that we have observed by the phase 3 clinical trials, we have observed 30%. Although this is a little bit just disappointing, but it is good to have we have some multiple options. Sometimes some patient actually cannot just some number one priority drugs because there's some medical condition or just drugs they are taking. So it is good that we have some multiple choices to prevent the progression to the severe COVID-19.
Right. Professor Kwok, this particular month, February, looks to be pivotal in our fight against the pandemic. Having said that, what are your words of advice?
Well, I think it's inevitable that we're going to go through it all together. But I think we need to primarily focus more on more vulnerable people, and I think that can be done only through vaccination. So we need to bring up the booster shot rates for the elderlies, but also let's not forget those in between ages of 5 to 12. There are children who are congenitally possibly more vulnerable to having the disease more severely and possibly from dying from it. Now, I'm not talking about completely healthy children who are just running around, but for those who are more vulnerable, we should let them be vaccinated. So I'm hoping the government will come up with a plan to process so that the vaccines could be allowed to be given to more vulnerable children who are between 5 to 12 years of age as well.
Right, 5 to 11 then, right? All right. Professor Kwok, as always, thank you very much for your thoughts today. And Dr. Kim, thank you very much for being with us.